Hi, welcome to Dental Notes and Mnemonics, and today we'll be discussing about the periapical pathology diagnosis. This topic will be in series of two parts, and today I am going to discuss about the inflammatory or the odontogenic reasons of periapical pathology, and the next video will be discussing about the non-tooth related or the non-odontogenic lesions which are responsible for the periapical pathology. So without any delay, let's get started with the video. Periapical pathology refers to any condition that affects the tissues surrounding the apex of tooth root, and they may be having the two main sources which can be broadly classified or categorized into inflammatory lesions or the non-inflammatory lesions. Inflammatory lesions are tooth related causes, mostly odontogenic also. These are directly related to issues with the tooth, like the infection in the pulp that spreads to the surrounding bone. And the second cause is non-inflammatory, non-tooth related causes or the non-odontogenic causes. These are not directly related with the tooth problems but can include things like tumor, cyst, infection that aren't related to the tooth itself. Discuss about the periapical inflammatory lesions, and here this chart illustrates the sequelae or the progression of pulpitis, showing how the inflammation of the pulp can lead to more severe dental and the bone condition if left untreated. First of all, it begins with the pulpitis. It is an inflammation of the dental pulp. It can either be acute, which feels to be sudden and painful, or chronic, the long lasting and the mild discomfort. If pulpitis is not treated, the inflammation spreads to the tissues surrounding the root of the tooth, leading to apical periodontitis. Again, we may divide them into acute or chronic. In acute apical periodontitis, it involves intense pain, while in chronic apical periodontitis is less painful but it is long lasting. And after that, the acute apical periodontitis can develop into an acute periapical abscess, which is collection of pus. Over time, if it is left untreated, this can turn into chronic periapical abscess. And chronic apical periodontitis can lead to periapical granuloma, which is a mass of chronically inflamed tissues at the root tip. If the periapical granuloma persists, it can develop into periodontal cyst, which is a fluid-filled sac around the root of the tooth. Untreated periapical abscesses can spread into the bone, causing osteomyelitis, which is an infection of bone. Osteomyelitis can be again acute or chronic, depending upon the duration of the infection. On the basis of localization or the spread of the infection, localized infection can be termed as focal osteomyelitis, and the infection that spreads more widely to the bone is the diffuse osteomyelitis. As the osteomyelitis spread, it causes periostitis, which is inflammation of the periosteum and the tissue which is covering the bone. This is often associated with bone thickening and pain. And if osteomyelitis or periostitis continues to progress, it can cause cellulitis, which is a diffuse soft tissue infection, or an abscess, a pocket of pus in the tissues. Depending upon the origin, periapical inflammatory lesions can be of pulpal origin or the periodontal origin. Please go through the list provided in the slide. Of nature of inflammatory response, we can divide into the acute periapical lesions and the chronic periapical lesions. Please, here again I have provided a list of the diseases or the lesions which are associated with the acute and the chronic periapical lesions. Please go through the list once. Third lesion in this category is the healing and the post-treatment lesions, which is a periapical scar. There is a formation of fibrous tissue after treatment or healing. It is asymptomatic and stable, and radiolucency without progression is diagnostic of periapical scar. Now we will discuss about the key differences between the acute and the chronic periapical lesions. First, the onset. In acute periapical lesions, the onset is sudden and rapid, often causing immediate discomfort. In contrast, chronic periapical lesions develop gradually and may go unnoticed for some time. When it comes to pain, acute lesions are known for the severe, sharp, and throbbing pain, making it difficult to ignore. Chronic lesions, on the other hand, often cause mild discomfort or can even be painless. Let's discuss about the radiographic changes in both the conditions. In acute conditions, early X-ray might show slight widening of the periodontal ligament space, while in chronic lesions display clear radiolucency indicating bone resorption. Regarding swelling, acute lesions can lead to pronounced swelling and abscess formation. However, chronic lesions tend to show minimal or no swelling at all. Finally, the histopathology. It reveals that the main difference at the cellular level. Acute lesions are filled with the neutrophils, a type of acute inflammatory cell. While in chronic lesions, they are dominated by lymphocytes and macrophages, indicating a prolonged inflammatory process. Now let's go through the key differences between the periapical cyst, abscess, and the periapical granuloma. Periapical abscess is an acute infection characterized by collection of pus at the root apex, and it is often painful and as a result of bacterial invasion in the pulp. Then on the other hand, periapical granuloma is an inflammatory response which is chronic in nature due to infection. It mainly consists of granulation tissue, but unlike an abscess, it is generally painless. And a periapical cyst is a fluid-filled cavity lined by epithelium. It develops around the tip of the tooth root, usually due to pulpal necrosis. If we talk about the radiographic features, a periapical abscess, however, appears as an ill-defined radiolucency with no clear boundary signaling any active or the acute infection. Then periapical granuloma also shows a radiolucent area that is generally less defined than the cyst and more rounded. And a periapical cyst shows up on X-ray as a well-defined radiolucent area with a clear border indicating a cavity. Though the definitive diagnosis of a cyst can only be made by histological examination, however, initially the clinical diagnosis of periapical cyst can be made on the basis of if the periapical lesion is involved with one or more non-vital teeth, the lesion is greater than 200 millimeter square in size. The lesion is seen radiographically as circumscribed, well-defined radiolucent area bound by a thin radiopaque line, and it produces a straw-colored fluid upon aspiration or as a drainage through assessed root canal system. Now we'll discuss about condensing osteitis, which is also known as focal chronic sclerosing osteomyelitis. It happens when the pulp of a tooth it becomes necrotic or inflamed, and this is usually deeply decayed, restored, and having a RCT with poor prognosis. The body reacts by making the bone around the tooth denser. That is why it is termed as sclerosing. The common location of this condition in the mandible and in the upper jaw, it is less frequently found, but you will often find it in molar areas. On an X-ray, we can see it is as a homogeneous radiodensity, a white area at the root apex without dark or radiolucent margin. You might also notice the widening of periodontal ligament as well. Let's go through the differences between the acute apical periodontitis and chronic apical periodontitis. Acute apical periodontitis is an inflammatory condition of the periapical tissues that typically occurs suddenly, and it is characterized by severe pain. This condition arises from the infection or the inflammation that affects the area around the tooth's root, as we have already discussed. On the other hand, chronic apical periodontitis is a long-standing condition that usually follows an untreated acute episode. It involves persistent inflammation around the tooth root, often resulting from untreated pulpal necrosis. Acute apical periodontitis, the patient may have a clinical symptom of sudden onset of severe pain. There may be tenderness or swelling in the periapical area. The patient possibly may have fever or malaise, which indicates a systemic involvement. On the other hand, in chronic apical periodontitis, the patient is usually asymptomatic, or if there is a discomfort, that is mild only. Tenderness upon palpation of the affected tooth is also present in case of chronic apical periodontitis. Acute cases, the radiographs may show minimal changes initially with slight radiolucency at the apex in some cases. But in case of chronic apical periodontitis, there is a presence of well-defined radiolucent area at the apex along with the evidence of bone resorption surrounding the tooth root. Chronic suppurative periodontitis is characterized by chronic inflammation in the periodontal tissues. This condition often leads to the formation of draining sinus or fistula, which allows the pus to escape from the infected area. Clinically, patient may notice a discharging sinus which may not be associated with significant pain. Guidelines for the diagnosis and the treatment of periapical lesions involves the initial assessment through medical and dental history. Intraoral examinations are performed. We should look for the symptoms of any swelling or the tooth displacement in case of large lesions. Radiographic x-rays are to differentiate between the lesions, assess the separation from the root apex. Pulse vitality tests are conducted to check the vitality, which involves thermal and electrical tests both. And for further assessment, the positive test suggest non-endodontic origin. We should consider a biopsy if necessary. And treatment includes the root canal treatment for confirmed endodontic lesions, and if the lesion is of not endodontic origin, then we have to re-evaluate the patient if the pain during the treatment persists. And the lesion size should be monitored over a year. Lack of improvement suggests the treatment failure. Consequences of periapical lesions involve the persistent pain, swelling, the displacement in case of large lesions, and if left untreated, the lesions may lead to secondary infections. Malignant lesions may cause a significant bone loss in the jaws, impacting the structural integrity. There is difficulty in achieving the successful endodontic treatment due to the lesion's nature, and there may be need for surgical intervention in some lesions. Can be malignant. Patient may experience longer healing time post-treatment, affecting the recovery. Chronic dental infections can influence the systemic health, leading to potential complications. American Association of Endodontic for periapical lesion have provided a guidelines based upon the size of the lesion. According to them, if the small lesions which is having less than 5 mm of diameter, for such tiny lesions, a gentle approach is taken with close monitoring to see how they respond. In the medium lesions which are 5 to 10 mm in diameter, and they have been diagnosed as needing the endodontic treatment, a root canal treatment should be performed, followed by checkups after 3 months. If the lesion does not heal within the 3 months after the treatment, it is essential to consult a specialist for further evaluation without trying treatment again. For the larger lesions which are more than 10 mm in diameter, it is very important to consult a oral and maxillofacial surgeon immediately, and they may decide to proceed with a root canal or not. Sometimes we may require a biopsy for the periapical lesions. The indications for the biopsy is if there is a lesion close to the root of the healthy tooth, a biopsy may be needed. If a lesion continues to grow even after conventional root canal treatment, it may require a biopsy. Any lesion near the root apex after the retreatment should be evaluated. If a lesion shows irregular radiolucency and tooth movement without sign of any periodontal disease, it is a candidate for biopsy. Lesions that change their appearance on X-ray and are distanced from the root apex should be biopsied. Any lesion that appears unusual on the X-ray, especially in the teeth with no caries, should be checked. If a lesion is persistent and causes abnormal sensations, it is advisable to consider a biopsy. If the patient has a cancer history, any ongoing or the growing lesion should be biopsied. Thanks for watching the video. In day-to-day practice, always look at both the clinical signs, what you can see in the patient's mouth, and the radiographic sign, what you see in the X-ray. Understand the difference between the tooth-related and the non-tooth-related problems. If you are unsure for the lesion, does not seem to behaving like a typical tooth infection, it's okay to refer the patient to the specialist or even consider biopsy for the closer look. So this was all about the inflammatory periapical lesions. We'll be tuning in for the next video with the concluding part of the same topic. If you found this video helpful, please consider subscribing to the channel for more in-depth discussions on the similar topics. Your feedback and questions are always welcome in the comment section. Thank you. Thanks once.